condition, it's localized, and it's non-type 2. Now, in that situation, I would actually advocate that if you have someone with recurrent unilateral facial pain with colds, and they have an anatomical issue that you can see on the scan, and it's unilateral, I would encourage you to go down the surgery pathway early. I wouldn't be giving this patient nasal corticosteroid sprays all the time to use, or use when they have a cold. I mean, you could talk to them about that if they were surgically adverse, but you know that if they're localized and they've got an anatomical problem, then you're absolutely right. You go down the pathway of surgery. Let's have a look at the other questions. I've been talking to keep the questions going. How long would you recommend treatment with macrolides? Okay, this is a good one. So if you take someone, thank you very much for that person who wrote that. They said, how long do I do macrolides for primary diffuse non-type 2 disease? Thank you very much.
So you see, your lectures are making an impact.
It's starting, Seymour Wise. It just takes a little bit of encouragement. And I'll answer that question very seriously because I get asked that question a lot. So I use clarithromycin because it's a 15-membered macrolide. It's available in my country, 250 milligrams. I do it once a day for 3 months. And at 3 months, if they are miraculous recovery, black and white, come good, perfect, I give it to them 3 times a week for the next 9 months. And then at 1 year, they can stop it. And that's right, 3 times a week. So if you look at some of the...
Can I ask you to repeat it, please? Repeat the...
So 250 milligrams clarithromycin once a day till 3 months. I make them the decision, did they have a clear response to macrolide, meaning they've really got to have normalized their sinus cavity. If they've normalized their sinus cavity on the macrolide, then they go to it 3 tablets a week. So they take it, Tuesday, Thursday, Saturday. And that's some of those strategies are based on diffuse panbronchiolitis and some of the Japanese lung disease where these macrolides first came from. You don't need much macrolide to get the response. And then at 1 year, I leave it up to them. I say you can stop, you can keep going if you want. And the only thing I do ahead of time for these patients is I get them all to have an ECG. And I tell them that they often ask, they say, oh, Richard, I've got to take a macrolide every day for 3 months. And I say, yep. And they say, is there any side effects? I said, actually, from a diarrhea, tolerability, resistance perspective, I said, there's almost nothing. That's been explored already. But I tell them there is one phenomenon. I said, if you have a pre-existing arrhythmia called a QT prolongation or prolonged QT, then it can make this condition worse, and therefore we get an ECG before you start. And I do that in someone who's had surgery and got a biopsy sitting in front of me, in which I can tell them that this is an approach that's likely to work. And they're usually a patient that's also sitting in front of me who's failed systemic prednisone as a way of getting their condition right. Okay, let's have a look at the next one. I would like to know about smell problem of CCAD. Yeah, so in CCAD, it's like any allergic rhinitis. It's actually very uncommon to see people with smell loss because they really only have this polypoid edema around this central middle turbinates. It's not like true eosinophilic CRS in which smell loss occurs very, very early. But in anyone who gets their smell back with oral steroid, I tell them that with well-delivered corticosteroid irrigations, they should probably get their smell back. In which situation do I use biologic agents is the next question. So the biologics we have on the market, which are essentially mepolizumab, which is for anti-IL-5, benralizumab, which is an IL-5 receptor blocker, and dupilumab, which is a 4/13 antibody. They are all for primary diffuse type 2 disease. Now, the only exception to that is omalizumab, which is IgE. Now, IgE technically should work in CCAD and AFRS because these are the 2 conditions that are thought to be IgE mediated. But there's really not much data out there for that. There's a bit of data on omalizumab for AFRS and really nothing for CCAD. And my personal feeling is that these patients, the CCAD patients, are just not bad enough that they end up in the world of biologics. And so it's really the primary diffuse type 2 patients that have terrible ECRS is where the biologics are going. Prof, how do we know that the sinus normalized? You look in with a scope. It's always on a scope. I think on a CT scan, you know, first of all, I don't know what it's like, Moaz, in Dubai, but no radiologist calls a CT scan normal in Australia. You know, they always say something. There's always some minor thickening or something else. So to me, I always look with a scope because they really have to have a mucosa that looks normal. It can be a little bit thick on the scan, but if there's no inflammation on endoscopy, then that's a good sign for me. And then how long to treat CCAD to decide for surgical intervention? Well, that depends on who they are. My current philosophy with CCAD is that it really is an exuberant allergic rhinitis. That's what we see it as. I like to get people started on immunotherapy. So they leave my office starting dust mite immunotherapy tablets or something else. And then I book them in for surgery in 3 to 6 months' time. I want them to go through their escalation phase. I want them to engage with the idea that they have an allergy and that's what the problem is. And then I do their surgery as sort of like the cherry on the top. And you know what? Taking that approach has served me very well because the patients do it for 3 to 6 months, you know, because they know their surgery is coming up and they think it's part of the surgery. And then they do it for at least 6 months afterwards because, you know, at the very least to please me. And if you can get someone 12 months into immunotherapy, you've done pretty well. And if you can convince them then that to follow through for the whole 36 months, then it's fantastic. Let's have a look here. But if I had a pilot, for instance, Moaz, who was getting barotrauma, and for CCAD, I'd give him surgery early on. I said, let's just get you sorted so you can fly again, and we can start the allergy treatment afterwards. I don't feel hard and fast about that. If you have a patient with primary diffuse CRS, I love it, and the CT scans don't show involvement of the sphenoid and frontal. Yeah, so if you have a patient who has a diffuse disease and both sides, and their frontal and sphenoid are relatively spared, so it's primarily ethmoid, I still do a full house VES. Yeah, you bet. And I do it because I want to make sure that everything's open and they're not going to get blockage. I also do it because the CT scan is just a snapshot in time of their condition. I do a full house VES because I know that these patients will get viral events and flare up and other things will happen, and you need a sinus cavity that will serve them well even during exacerbations. And I do think that when you see a scan in which it seems to be sparing the sphenoid and frontal, you should think of CCAD. Let's go down the next one. Do I prescribe macrolides immediately after the pathologic report? No, I don't. I do pretty much do it at the report. I don't wait for them to fail a corticosteroid irrigation approach and be 3 months out. That's actually, I see that as a failure. And you know, that's how I actually started macrolide treatment, because I used to, like probably many of us, I used to give macrolides as a sort of like a kitchen sink approach for some patients who weren't going well. And then I had these patients, once I started doing the biopsies, that would come back and see me. And I swear, I thought they'd come good on a corticosteroid irrigation. This is back in, 2009, 2010, when we were just starting doing corticosteroid irrigations. And I thought they'll be a winner on my steroid. And they just looked awful at 3 months. And I couldn't understand what was going on there. And I started looking back at their biopsies and I could see that they weren't eosinophilic. So that's how I started doing it. So I don't wait now for them to fail. If I see non-eosinophilic report on the biopsy at their 3-week visit, and they have the clinical features of someone who's likely to be non-eosinophilic, then you bet I start their macrolide then and there. What is your solution of sinus washout after surgery? I'm not going to answer that because it hasn't got a classification code as to what type of sinus disease we're talking about. Can we please have a look at the eosinophilic RS report? Yeah, I sent it to Moaz, so I passed the buck to Moaz there. He's got the PDF.
Yeah, it is on the chat line, so I think
it might be to you privately. I don't know how to get my private.
Okay, all right, okay.
You might have to. Oh, here you go. Here you go. I sent it to everyone. Here you go. I just realized I could send it to everyone. There you go. Here we go. I'll send it to everyone. You're absolutely right. I could the drop down menu there. It's coming through now. Let's go. Send that. The role of drug-eluting stents. Yeah. It's just another way of delivering corticosteroid. So I think any type 2 disease could benefit from a stent potentially. It just depends on how much you think $800 is worth for 28 days worth of steroid decay in the sinus, and the cost-benefit ratio there. It's not something to be sniffed at, you know. Oh my gosh, someone's asked me, how do I deal with post-nasal drip? So that's another story, Moaz. Look, I'm very pleased. The only thing I can say about that is that, Moaz, I'm very glad that's the topic that you didn't give me to talk about post-nasal drip. You know, at the end of the day, that is something that plagues us all. I think we now recognize that actually a lot of these patients have just a sort of a non-specific irritation of their rhinopharynx. And probably a lot of them, it's probably reflux, extraesophageal reflux. But it's not an inflammation, it's a chemical irritation they're getting. And I think that how we're going to manage that over the years is tricky. You know, I've got a few projects in that field, but you know, many projects I've done that you've never seen the light of day in publication was trying to sort of sort out inflammatory postnasal drip from chemical postnasal drip from neurosensory or hypersensitivity postnasal drip. And I've still yet to find an answer. So I can't profess to be an expert there. Which of the local steroids do you forms? I almost always use corticosteroids for sinus disease. In terms of corticosteroid irrigations, I use nasal sprays for treating rhinitis. So if you have a rhinitis condition, I use nasal sprays. If you have a sinus condition, I use irrigations. That's just all about getting it there. What do I think of the role of doxycycline in CRS with polyps? I almost don't want to answer that, Moaz, because someone said CRS with polyps. Can that person rephrase it for me and give me a condition? You know, doxycycline. I would think that they're talking about this idea that Klaus Bakkertsworth suggested that doxycycline might have an anti-type 2 inflammatory reaction, blocks the type 2 immune response. It's so weak, that response, that I really don't use it. There's no doubt that when you use doxycycline, you do get rid of staph, so you get an anti-staph effect. But really, as an anti-inflammatory agent, I don't give doxycycline much credibility, in my opinion. I acknowledge that it's probably there, but it's very, very weak. Prof, we didn't get your slide, so I did. Moaz, did you see the PDF?
Yeah, it is.
Yeah, so the PDF should come up, guys. There should be the PDF.
I think if you're using the phones, it might not come up.
Yeah, okay. It's in the chat. It's in the chat group. You'll see it there. You see it there. I'll for the sake of it, I will. I'll send it again. But yeah, it's definitely there. I'll send it another time. Here you go. What other questions have we got here? What is the solution for primary diffuse eosinophilic or type 2 polyp disease? I use a corticosteroid irrigation. Surely, Moaz, in Dubai, you've got many different types of corticosteroid irrigations, yes?
Absolutely.
Different ways of making it, yeah, okay. So I'm not going to go into that. There might be someone who, you just need to have a look at the many publications, whether it's a budesonide irrigation, a mometasone irrigation, a betamethasone irrigation. These are the ones that are around. These are all the things that we use. Now, here we go. This is, yeah, someone said to me, I've sent through the histopath report. On the histopath report I sent through, it's got our template, but on the back couple of pages is the instructions for the pathologist, and it's written by a pathologist. So it's something that you can just send that PDF on to your local pathologist, and if you can sweet talk them and explain to them how important getting a little bit of information in helps you in your practice. And I think I've sort of caught up to where we are. One thing here, Full House Fest. So someone asked me here, George B said, after Full House Fest and optimal control, how often do you have empty nose syndrome? So let's make it very clear. Empty nose syndrome is a condition of anxiety and hyperventilation. There is no nasal surgery that causes empty nose syndrome. We have a PhD at the moment who's going to produce some sort of papers on this. Empty nose syndrome is a condition in which patients believe they can't breathe through their nose. They get very anxious about it. It is essentially the hyperventilation disorder of the upper airway. And then very unfortunately, they buy themselves operations. And then the operation is traumatic. They often feel then worse afterwards. They have absolutely no organic pathology to see. And they have this terrible sense of like impending doom, I'm suffocating. This is not caused, it's not a condition of the nose or surgery. It is a condition of anxiety, hyperventilation, and somatosensory disorder. Now, I know there are people around the world who still talk about whether I took a little bit too much Turbinate or not enough too much Turbinate, and this caused all my problems. These people are playing in a zone in which they just don't understand that there's a huge group of people that operate on patients for serious conditions, big tumors, take out all things out of the nose to treat people with cancer and tumors. And these patients never develop empty nose syndrome. It's not because they're just thankful to be alive. They simply do not get empty nose syndrome. Empty nose is a pre-existing sort of anxiety, hyperventilation, somatosensory disorder. And I think that's very important to people on the panel and the web chat that they understand that. We need to get away from talking about that as being a result of surgery. Now, there's no doubt that it's iatrogenic in the sense that if you operate on someone who really has a normal nose and they have anxiety, hyperventilation, you're going to make it worse, you know? So there's no doubt that, you know, surgery makes the whole thing worse, but not because of whether a bit of turbinate or all the turbinate or part of the turbinate is missing. That's got nothing to do with it. Okay, what are we up to? What is the role of IgE in allergic rhinitis? IgE is the mediator of allergic rhinitis. That's why immunotherapy works. What else can we ask here? Any other questions, Moaz, you have on the card?
Thank you very much. I'm just trying to give them my email so I could send it to them if they don't have it. Because they have, usually what happens is that if you're on the phone, it doesn't download, but if on the computer, it would. Listen, thank you very, very much. I think it's time for you to go to sleep. What is it, midnight now? It's midnight?
It's midnight now. Thank you for having me, and I hope, as usual, I've stirred a few up debates as much as I answered some questions. Really. So
what amazes me is how energetic you get about this, and how focused you are on this, and the time you really your attention and your commitment to teaching and making sure that other people understand what you're talking about is really admirable. So thank you, Richard.
That's very kind of you, Mars. Thanks for having me, guys. Thanks for listening. I appreciate it.
Thank you. So enjoyed having everybody here. Enjoyed having Richard.